many of these. Not only do we all become proficient with making an implant-supported provisional restoration, but we become proficient with making the flipper an ovate ponic design. I can't tell you, regardless of how many times we ask, we very rarely get what we want, and this can simply be created within minutes chairside with a flowable composite or acrylic by roughening the underneath surface. Here we are prior to inserting it. We want this to apply good pressure into the extraction site and support that facial gingival margin as well as the papilla. Here we are at 1 week with good maintenance of the soft tissues, still going through our healing phase, and a month later getting ready for our implant placement with indexing for a stage 2 provisional. So here's our surgical index with what I would call more of a papilla-sparing peekaboo incisions just to get enough access to place our implant. I'd say today we're doing much more of a flapless approach than this, but even back at this time we were doing everything we could to do a minimally invasive procedure. This is after healing, so the patient had the implant placed and indexed, went back into the ovate ponic design removable prosthesis, and from our surgical index we used a preppable gingiva abutment and fabricated an acrylic provisional that mimics the tooth shape that we're trying to achieve, but we're still not quite to the standpoint of closing that diastema. But as you see, it'd be impossible for us to go through the provisional stage with the restorative dentist without taking into consideration that we've got to change the midline. So we've got to have a provisional on the implant before we can get to preparing that adjacent tooth. And this is just another example of a well-made laboratory fabricated provisional that's going to be inserted at uncovering. So we'll let this heal and we'll come back now right prior to provisionalization of the natural teeth and do a little gingivoplasty, gingivectomy to get where we're headed. This is our final result, and you know, if anything, the criticism is that we probably need to do some crown lengthening instead of gingivectomy. You can see the facial gingival margin on 9 has already crept back, and I've tried to offer this to this patient at no cost many times, and she won't let me touch her. So she's done, and you know, considering where we started in regards to you know, the whole smile design of the case and closing the diastema, she's quite happy. This is another question that comes up very often when we have to deal with canines, and especially canines in parafunction. You know, how slowly do we want to tread on these cases? In my opinion, is unless it's just a rare case where the canines can be left out of occlusion, we'll always stage these and still implement a provisional restoration for slowly, progressively loading the implant. So slowly building that canine back into guidance with a provisional restoration before we go to final. This is a case I won't show you the final on, but I'll show you to the provisional stage. I mean, a very deep bite. This patient's an orthodontic patient, really, but he's going to lose his canine. That reddish hue, we know we're in trouble, and as you can see, the resorptive lesion was incredible. Completely had undermined the entire crown. So here we're doing our surgical index, implant placement with just a cover screw and grafting the horizontal defect around this implant, using our trusty ovate ponic design provisional restoration to support facial tissues and interproximal tissues, and coming back with a biopsy punch technique to expose our implant and connect a screw-retained provisional restoration that's properly contoured. And in centric, we are putting a little bit of occlusion on this, but trying to limit it in excursions, as we'll see in just a moment. Here you can see the screw axis will just fill in with a cotton pellet and some Cabot material or IRM, whatever your preference is. And here we are, day of delivery of our provisional. This is sometime later, showing that as we go into excursions, we've left the canine out of complete function there. And the patient is happy and soon will be moved towards his final restoration. Now, another example of a case where we want to consider all the different options here. We've got a hard and soft tissue defect to deal with. Root resorption, once again, significant root resorption. And this, in my mind, is not a case where we want to immediately provisionalize an implant. We've got too much tissue to rebuild. but we will. Here's a facial profile showing the facial deficiency of soft tissues that we need to recoup. Our diagnostic wax-up that becomes the key portion of the roadmap towards success. Here's our analysis of the extraction defect and implant preparation for immediate placement, and our horizontal defect that is grafted, and trying to limit it to approximately 2 millimeters by our planned implant diameter size, our surgical index that's taken, the grafting of the horizontal defect, slight clinical crown lengthening on the adjacent central incisor, a connective tissue, subepithelial connective tissue graft is harvested to an attempt to do our first soft tissue rebuilding of the case, and a little collagen, quickly resorbing collagen material to help dress that wound. And then our ovate ponic design interim partial denture is utilized to support tissues at a week. We're looking at the collagen material there, and at a month we're happy that we've maintained the connective tissue graft and have a good start here at rebuilding the loss of soft tissue. And another picture of our chairside modified ovate ponic there, very simply done with some flowable composite. Here we are getting ready for stage 2. We've done a good job at rebuilding some of that soft tissue, but you can see on an occlusal view there is still a depression that we're going to correct at provisional insertion. This little peekaboo flap to allow to get this abutment down without tissue impingement or tissue preventing us from getting it down all the way, and then the provisional restoration properly contoured. Then we'll take our second subepithelial connective tissue graft and just to show you the size of it, and then kind of tunnel this laterally to try to rebuild. Early on in healing here, we see that we still have some clefting that we want to come back in plasty, and we are also going to be placing a restoration on the adjacent tooth. Fortunate enough to do this case with my wife, so she's a restorative doctor here, prepping the adjacent tooth for a veneer restoration. And again, another example like the diastema closure where we couldn't do this without a provisional on the implant. We need to have developed the contours of the tissue before we move on to this step of final impressions. So here, the case I showed at the beginning of how well we've re-established the facial soft tissue profile and how we've created the emergence profile from the implant platform. We're going to go through the same process of creating a customized impression coping. So this is the abutment that's in the mouth put on an analog. You can see here how we've lost some of the marginal integrity. Simply reline that with a flowable composite and polish. Here's our provisional relined and improve the contours of it. Here's our impression coping placed on the analog and our blue mousse material around that, recording the shape of our provisional restoration. This is the customized impression coping, and I'll just put take a Sharpie and mark the facial aspect of that just for ease and delivering it to the oral cavity to line it up correctly. Depending on the system, it may not be as important, but with this implant system, we've got a 3-prong index, so to say, and we want to make sure when we put this into the mouth that we've got it in the right position, right orientation. So here's our impression. Again, we're impressing both the implant and the adjacent veneer preparation and moving forward to the laboratory process. I'll share this laboratory process because this is one of the most talented technicians that I've worked with in regards to creating a porcelain infused to metal abutment. Going back to his wax-up, showing in the anterior zone how difficult it would be to consider an implant design that has us cement a restoration near the implant platform. We're looking at close to 6-7 millimeters interproximally. That's quite deep. So we need to be thinking more and more about customization into anterior zone so that we can have retrieval ability of the cement. Here's the cutback of the metal abutment and then the porcelain addition. Here's on the model looking at where he's setting us up for a very, very, very accessible restorative margin. And here's our adjacent veneer, porcelain infused to metal abutment and porcelain infused to metal crown. Another example of it on an analog or a practice implant there. In side profile, just a very nice job at creating a well-contoured restoration that mimics what our provisional did for us. and to the day of seating. Still got a little clefting over here that will ultimately come back in plasty. As this case goes forward, we'll look here first at where we started, short clinical crowns on the central, so we have some freedom to come in and do that crown lengthening on the adjacent tooth. Here's at the provisional stage, where we haven't prepped the natural tooth, but we've gained some clinical crown length, and we still have healing around the distal aspect of the implant restoration. Now we're on to our final restoration, and with time, this is going to start to look better and better as far when the tissues start to mature and that cleft is reduced. But we're certainly comfortable with the amount of tissue we've regenerated there so that we can have a long-term predictable result, showing good maintenance of bone levels. You'll see on most of these immediate implant placement cases that they're placed rather deep. And that, I think, is one drawback of immediate implant placement into extraction sites. We tend to protect ourselves by going a little bit deeper. And certainly in cases like that, you need to be thinking about how you're going to transition getting the cement line up to an accessible position. And here our patient is today. Another canine case, and for the same reasons, in this case we're going to stage the implant provisionalization. We can see that we not only have to recoup a tooth here, we've got to recoup the soft tissue profile or the canine eminence that we will plan into this case at the time of implant placement. So first implant placement, using some osteotomes to expand the ridge. Implant placement. Here's a second guide that the prosthodontist has made me to verify the position. I believe we'll have a measurement picture coming up. Here's implant placement. Here it is. This is the second guide that he's made to tell me that he'd like this proposed CEJ to be 3 millimeters from the implant restorative margin. Our indexing performed, our connective tissue ridge augmentation conducted, and still using the removable appliance to work these tissues. And now is the time we'll be working back in the laboratory to create a screw-retained provisional restoration. And upon implant uncovering, that picture shows nicely our ability to reform the canine eminence area with just soft tissues. See a very nice result of what our osteotomes did for us to build up the dimension of buccal bone. Our screw-retained provisional restoration to give us a nice tight seal with no cement issues. Coronally advancing the flap, probably beyond where we need to, but certainly even if we have to come back and over-contour the restoration, the provisional, to get that tissue to move apically, I'd rather start with it further coronally than not enough. And here we are in the provisional stage, allowing tissues to mature and heal. You can see again that we want this to ultimately go a little bit further apically, but this is a nice problem to have at this juncture. We still got some maturation to occur in the papillary areas. And moving on with a different technique for this prosthodontist, but it's still a customized impression coping here. He's just used Duralay versus a flowable material to create a customized impression coping and pick up these contours and transfer those to a master cast. Here we're going with a porcelain fused to metal abutment with a porcelain fused to metal crown, a veneer for the lateral incisor, and a mesial MO inlay for the bicuspid. And here we are very shortly after seating, still waiting on some papillary fill, and we're moving along to a standpoint where we're much more happy with how the tissue is maturing, and the tissue has receded a bit, and we're really not going to do anything with that. We'll just let it be where it's at and probably have some subsequent recession there. But canines, our case is really to think towards a delayed approach, but still using a provisional restoration